Today, we're getting under the hood of women's health with Dr. Bernie Russell, a board-certified OBGYN based in New York City. Dr. Bernie is a daughter, mother, advocate, counselor, and friend who focuses her work on trauma-informed gynecology and focuses her play on connecting thinkers, makers, and empaths to advocate for a world where we recognize and celebrate the human journey. Dr. Russell will get under the hood of postmenopause.
I'm Dr. Bernie Russell. I practice here in New York City. I have practiced in various environments, and I have been in my own private practice for over 24 years. One of the privileges of that is that I've had the opportunity to see my patients grow as I've grown as a physician. They've taught me about themselves and their life stages as we've progressed together through over 20 years of care. Postmenopause is defined by something that we kind of don't know that it's happening when it happens, which is our final menstrual period. Once we're a year beyond our final menstrual period, then we say, okay, that was the final menstrual period. So we're kind of looking in the rearview mirror in order to see when was that time and defining it by that final menstrual period. 1 year later, you are postmenopausal. One of the most important ones are heart disease. Heart disease ticks up in this time frame, and it's really important for women to know 1 in 3 women will die of heart disease. And the data shows that less than 8% of women are aware of that. So it's important to know what those risk factors are. Do you have a family history of heart disease? Do you yourself have diabetes, high blood pressure, cholesterol concerns? And if you have those concerns or issues, that would be an indication to get further screening and testing. Again, one of the ones that's talked about as far as symptoms is brain health, right? And it's very important to know that there can be changes that occur in the menopausal transition, and those changes do not signal a deterioration of overall health and well-being. But if you've gone through the menopausal transition and you're entering into postmenopause and you're finding that you're having more problems with memory, more problems with what some people would call brain fog, focus and concentration, that would be a very good indication to get further neuropsych testing, neurologic and psychologic testing to find out if this is something that is telling us something more about early Alzheimer's, for instance, or other medical issues which could be affecting memory. I think that menopausal hormonal therapy is an important therapy available to women. Its biggest impact, its biggest potential benefit is seen in the menopausal transition. So when we're seeing someone who is a year after their last period, the benefits that we can accrue from menopausal hormonal therapy begin to diminish, and the risks begin to be a bit more of concern, because it's as we get older and you may see blood pressure creep, you may see cholesterol be a bigger issue. It's at this time that we have to sort of see, where are we with menopausal hormonal treatment and whether or not it needs to be continued, suspended, or just redirected. When's the best time to talk to someone about bone health? Kind of like in their 20s and 30s, so that they can get the peak, bring the peak to its highest, because after you have a period of maintenance of bone health, of bone density, there's going to be diminishment as we get older. One of the most important things to do is to maintain lean body mass, right? So stay strong. And if you haven't been strong, get strong. Supplement calcium. I really encourage patients to eat calcium-rich foods. I think that's really important. And for people of small frame, for people with family history, it's important to really say, are we doing our very, very best? And is there medical intervention that we should be doing? Should they be osteoporotic? Should we identify osteoporosis? Osteoporosis is a condition, and the bones are not static. We don't have the bones that we had last year, much less, 20 years ago. Bones are constantly being broken down and built all the time. It's a metabolic process. I smile when people ask me about libido because as a gynecologist, I have 20-year-olds asking me about libido just as frequently as I have 60-year-olds asking me about libido. And so when people link libido and libido changes to the menopause only, I find that interesting because libido is not a simple one button situation for women. If you can visualize it, I used to show patients this kind of really funny motherboard comparison. And I can make my apologies to the guys from now. But on the guys' motherboard, I showed them a single button, green button, and you could kind of hit it, and there you go. I'm turned on. And then I showed a woman's motherboard with multiple lights and bells and colors and, multiple buttons and levers. And I said, yeah, that's your libido. Your libido is a little bit more complicated. Why? Because if you don't feel good about yourself, it does impact how you feel about your partner, and it does impact how you feel about engaging sexually in general. After the menopause, in the postmenopausal period, we see higher levels of heart disease. And while estrogen seems to be protective and women develop heart disease maybe 7 to 10 years later than what we're seeing in men, as a group, what we're seeing in men, when women develop heart disease, our outcomes are worse. And that's really important to recognize. It's really important to state. It's really important for women to know that they are at risk for heart disease because 1 in 3 women will have heart disease. So knowing the risk factors, do I have a family history? Am I a smoker? I should start with smoking. The single best thing you can do for your health as a woman who's postmenopausal is stop smoking. What we know is that it's not just women and the population, it's not just women who don't understand the risk for heart disease in women. Doctors don't understand the risk of heart disease in women. 2/3 of doctors don't identify heart disease as a significant risk for women. And so women need to know diabetes, high blood pressure, smoking, family history, sedentary lifestyle. These are all things we have to be focused on and making improvements. You should know your blood pressure. You should know your cholesterol. You should know these numbers so that you can make a change if change is necessary. If change is necessary. And you should begin to view yourself as someone who, as a whole, needs to be listened to, needs to be interacted with such that you can maintain your health or be treated or seek treatment if that's necessary. So the incidence of breast cancer increases in women who are postmenopausal. And so it's important to be going for screening. And in our environment, screening means mammograms. I have a lot of patients who are concerned about having mammograms. They're concerned about finding things. I'm concerned about not finding things. So I believe a mammogram is a good screening tool that should be utilized in postmenopausal women. I've taken care of women who have the diagnosis of breast cancer, but most people being diagnosed with breast cancer, early breast cancer now, are doing well. But I will see them next year and the year after and the year after. And by the time I see them 5 and 6 and 7 years after, I'll be like, when was it again you had breast cancer? I don't even remember. When was that? Hold on, let me check the chart. So I think that it's important to say that estrogen and the brain, fascinating interplay. But that interplay and our understanding of menopause in the brain can't be isolated from a society that views women and our competence and our interaction and our involvement through a lens of, oh, you're hormonal. And what we know is that there are significant, potentially significant responses that people have in the menopausal transition, and that most of those significant changes are time limited, and that in the post menopause, they should be better. And they should not have as many experiences with word finding trouble, and new learning can be more difficult in that time frame. And we haven't turned our attention to the wisdom, or we haven't reminded ourselves of the wisdom that we know comes to in this group of women because of their very, very powerful menopausal brain. So one of the first things that I use to discriminate, to determine what do I put on my list of things to consider, one of the first things is age. So in the postmenopause, cancer rises up on the list. That does not mean that it is the first thing on the list. It does not mean that it is the most likely thing that the symptom is related to, but it means that it's high enough on the list that I should make sure it's off the list before I have further discussion with the patient. So endometrial cancer, bleeding after you have not had a period for a year, needs to be fully evaluated. So bleeding is one. Breast cancer rates increase as we age. That doesn't mean that breast cancer outcomes are worse as we age. Early detection still is tremendously beneficial. And I would encourage women as they age not to opt out or not to be opted out of screening. I'm interested to see what other things you can create in the world in your menopause. Um, it's a time of change, gestation, right? You're not gestating this human form to go forward in the world. You can gestate your ideas, you can gestate your friendships, you can gestate your impact in the world, because the happiness data has clearly demonstrated to us that it's a check mark. And once you get through that nadir of the 50s, happiness should increase and increase and increase. And whenever things are really terrible, because I'm in my 50s, I go, it's got to get better. It's got to get better. All the data shows it's got to get better. Right. And so that's what I would encourage people most.